Hi, my name's Andy Kilcross and I'm a GP. Today's presentation is all about common skin infections, many of which we regularly see in the primary care setting. In today's presentation we're going to cover a number of things. Firstly, we're going to have a look at skin anatomy and physiology. Next, we're going to consider some common bacterial skin infections. Then we're going to look at some viral skin infections, and then some common fungal skin infections, before finally considering other common causes of skin infections not previously discussed. Let's begin first of all then with a refresher in basic skin anatomy and physiology. The skin is a very important organ. In the average adult, it makes up approximately 16% of body weight and covers an average surface area of approximately 1.8 square meters. I like to think of the skin as being a bit like lasagna, in that it's made up of many different layers. Let's have a look now at some of these layers. The uppermost layer of skin is called the epidermis and is packed full of cells. There are three main types of cells within the epidermis. Firstly, the keratinocytes, which make the protein keratin, helping to form a layer of armour around us. Keratinocytes are arranged in what's referred to as a stratified, i.e. multi-layered, squamous epithelium. The keratinocytes begin their life in the basal or bottom layer of the epidermis, which is shown here as a tortuous purple line. Over time they mature and then migrate upwards to the skin surface in a constant cycle of replenishment. The next type of cells in the epidermis are the melanocytes. These are found around the dermoepidermal junction, that is, the junction between the dermis and the epidermis. Melanocytes produce the pigment melanin, which is important in helping to protect the body against ultraviolet radiation. The final type of cell within the epidermis is the Langerhans cell. These are involved in the immune response and present antigens to lymphocytes. In summary, the epidermis is a highly cellular part of the skin, composed of many layers of cells. However, it's relatively avascular and lacks nerves. The next layer to consider in our dermatological lasagna is the dermis. The dermis is relatively acellular, but contains a number of important components. First of all, it contains pilosebaceous units, which you can see here. The pilosebaceous unit contains the hair follicle and the attached sebaceous gland. The sebaceous gland produces an oily substance called sebum, which helps to lubricate the surface of the skin. Also within the dermis you'll find blood vessels, nerves, and a number of different cell types. The first cell type is called the fibroblast, and these are responsible for making connective tissue called collagen. Another type of cell found in the dermis is the mast cell, which, in certain situations, is triggered to release inflammatory mediators such as histamine. The next layer of skin is called the subcutaneous layer, or the hypodermis. This layer is composed of loose connective tissue, lymphatic vessels, blood vessels, and fat. With this presentation being about infections, it's important to talk about normal skin flora. The skin is naturally covered in an enormous zoo of different microbes, including bacteria, yeasts, and mites. The number and types of such microbes changes between individuals, in different body sites, and also in response to a number of other factors which can influence the skin's microbiome. Generally, viruses are not thought to be commensals on the skin. Let's look now at basic skin physiology. The skin has a number of very important functions. Firstly, it acts as a barrier to a number of things. For example, it helps to protect against trauma. It also acts as a barrier to a broad range of noxious agents, such as chemicals, ultraviolet light, and the pathological microbes that this presentation is about. Secondly, the skin is a waterproof barrier, helping to prevent fluid entering the body and also fluid being lost from within. By way of example, we can see the problems associated with a breach in the skin's waterproofing when patients sustain major burns. In this situation, when the all-important barrier is lost, patients are prone to losing large quantities of fluid, often requiring urgent fluid resuscitation. A third vital role of skin is as a regulator of body temperature, which it does by a number of different mechanisms. Fourthly, the skin's involved in vitamin D production, a vitamin which is very important for bone strength. And finally, the skin's a key sensory organ, constantly sending information to the central nervous system about the person's environment. We said that one of the skin's most important functions is as a barrier to noxious substances, and one example of that is as a barrier to pathological microbes entering the body. We can split such microbes up into broad categories, namely bacteria, viruses, fungi, and other microbial life. We're going to look now at these groups in more detail and begin our journey by reviewing some of the common bacterial skin infections seen in general practice. Two of the commonest bacteria that can cause skin disease are Staphylococcus aureus and Streptococcus pyogenes. Staph aureus is carried by approximately 20 to 40% of people in their nostrils and less commonly in other sites such as the perineum, toe webs and axillae. There are certain factors which promote its carriage, such as warm weather, high humidity, the presence of other skin disease, patient age, poor hygiene, crowded living conditions, and neglected minor trauma. Staph aureus can be the primary cause of skin disease, or sometimes can cause a secondary infection, superimposed on a pre-existing pathology, such as eczema. The second common bacterial cause of skin infections is Streptococcus pyogenes. This is also known as Group A beta hemolytic streptococcus, or GAS for short. Strep pyogenes' carriage is promoted by very similar factors to Staph aureus, and again colonizes the skin and other sites, such as the nasopharynx. We're going to have a look now at some of the common skin infections caused by Staph aureus and Strep pyogenes. And the first such condition is impetigo. Impetigo is commonly known as school sores or golden staph, so called because it's commonly seen in school-aged children and because it produces a golden crusted appearance on the skin. We often see impetigo in pre-existing skin problems such as eczema and scabies. In fact, it's always worth looking at pre-existing skin conditions such as these to see if you can find the golden crusting typical of a superimposed Staph aureus infection, because if present, this will also need to be treated if the primary skin problem is to fully recover. Impetigo can also present with a number of other skin lesions, such as vesicles, bullae and pustules. While in the main impetigo is caused by Staph aureus, in approximately 20% of cases it may be due to Strep pyogenes. Impetigo would typically be treated by a number of measures, including removal of the crusts with saline soaks, antibiotics and antiseptics. With impetigo being highly infectious, it's also important to talk to patients about hygiene strategies and so prevent spread to others, such as hand washing and avoiding sharing towels and flannels with others. The next bacterial skin infection to consider is folliculitis. This is a pustular skin infection involving multiple hair follicles, and it's most commonly caused by Staph aureus, although may be caused by other microorganisms such as Pseudomonas. As you can see from the picture here, folliculitis presents with multiple tiny pus-filled lesions, each originating from an individual hair follicle. It's seen in a number of situations, including hair extraction, such as shaving, plucking and waxing, occlusion of hair-bearing areas by things such as clothes, plasters or plastic film, warm moist climate, diabetes, topical steroids and systemic antibiotics. There are a number of methods available to treat folliculitis, and these include antiseptic skin wash, systemic antibiotics, and attempting to reverse the contributory factors above. The next infection in line is the furuncle or boil, an example of which is seen here in the picture on the left. Furuncles are abscesses that form around a single hair follicle, and they tend to present as tender, red, warm, pus-producing lesions in hair-bearing areas. Whereas furuncles involve a single hair follicle, the image on the right shows a process by which a larger abscess forms around multiple hair follicles. This is called a carbuncle and leads to a painful, hot, red, suppurative mass, again in hair-bearing areas, but generally of a more significant size than the furuncle. In treating these, it's important to remember that abscesses are walled-off collections of pus. It may sometimes be possible to treat a furuncle with oral antibiotics, but generally speaking, a carbuncle, and for that matter larger furuncles, will typically require surgical incision and drainage. The next condition in this presentation is called scalded skin syndrome. So called because, as you can see from the picture here, it presents visually in a way similar to that of a skin burn. Scalded skin syndrome is caused by a toxin released from Staph aureus, which causes a splitting of the skin layers. As the image demonstrates here, it's typically seen in young children and may follow a pre-existing bacterial skin infection such as impetigo. Scalded skin syndrome may be a serious condition requiring hospital admission and management, including intravenous antibiotics and aggressive fluid and electrolyte replacement. Next, we're going to have a look at cellulitis and the closely related condition called erysipelas. Cellulitis is an inflammatory condition of the deep dermis and subcutaneous tissues caused by infection, again most commonly by Staph aureus or strep pyogenes. As you can see from the image on the left, cellulitis typically presents with a hot, swollen, red area of skin that's well demarcated, and in a similar way to impetigo, will often occur when bacteria enter the skin through a breach in its barrier, leading to infection. Erysipelas can be thought of as a type of cellulitis, but one that typically involves more superficial levels of skin as well as the lymphatic system. Cellulitis can occur in most parts of the body. Common sites for erysipelas, however, tend to be the face and lower limbs. Erysipelas presents with sharply demarcated borders, but what looks often like more swollen skin due to involvement of the lymphatic system. Again, erysipelas tends to occur when bacteria enter a breach in the skin's barrier, such as through a fissure or crack. Note that both cellulitis and erysipelas may present with additional systemic symptoms, such as lethargy, fever and malaise, as well as local lymphadenopathy. Cellulitis and erysipelas are treated with antibiotics, which in mild to moderate cases may be given orally, or in more severe cases, intravenously, in conjunction with admission to hospital. As you can see from the image on the left, a very useful tip is to draw around the border of the cellulitic patch in order to monitor progress and make sure that the condition is responding to treatment. We're now going to move on to the second group of microorganisms to consider in common skin infections, namely viruses. There are a number of such viruses that commonly cause skin pathology in the primary care setting. The first of the dermatological viruses to think about is human papillomavirus, or HPV. In microbiological terms, there are many different subtypes of HPV. Broadly speaking, we can classify HPV into those causing cutaneous disease, which affects the skin, and secondly, those causing disease of the mucous membranes. Of the different presentations of cutaneous HPV, common warts, as shown here in the picture on the left, makes up about 70% of cutaneous presentations. Other fairly common cutaneous presentations include plantar warts, also known as verrucas, as shown here in the middle picture. Mucosal HPV can infect the anogenital region, the mouth's mucosa, the throat's mucosa, and also the conjunctiva. It's worth remembering that anogenital HPV is the commonest sexually acquired infection in Australia. It's also known as condyloma acuminata. It's important to remember that there are a small number of HPV subtypes which are what we call oncogenic. That is, they increase the risk of cancer development. One of the key examples of this are the oncogenic HPV subtypes linked to cervical and other anogenital malignancies, and for which we offer cervical screening and also immunisation as part of the National Immunisation Programme to help prevent HPV-linked cancer in those who've yet to be exposed to oncogenic subtypes. When people present with warts, there are a number of ways in which these can be treated. Methods include cryotherapy or freezing, topical preparations such as those based around salicylic acid, and in the case of genital warts, topical podophyllitoxin. Occasionally, patients with active HPV will be referred for more specialist measures such as laser treatment. Next in our tour of dermatological viral infections, we're going to consider herpes simplex virus, or HSV. There are two main types of HSV, namely type 1 and type 2. Historically, type 2 herpes simplex virus has been associated with genital herpes, while type 1 has been found in places other than the genitalia. Although it's important to emphasise that type 2 HSV can be found outside the anogenital region, and equally type 1 can cause genital infections. HSV is passed on by direct contact with the lesions. Once contracted, the virus lives in the dorsal root ganglia of the nervous system and can reactivate at a future time. A number of factors have been implicated in the re-emergence of HSV, including immune suppression, altered hormone levels, and stress. Typically, acute HSV infection presents with a number of stages. Firstly, patients may experience discomfort or tingling in the area, followed by the emergence of vesicles. Vesicles are small, fluid-filled blisters which contain a golden-coloured liquid. Subsequently, vesicles may erode into ulcers before crusting over and eventually resolving. Patients may experience associated fever, malaise, and local lymphadenopathy. The lesions of HSV can be extremely painful. For example, genital HSV acquired sexually can cause severe discomfort and resultant difficulty passing urine and even urinary retention. Acute HSV infection will typically last for a couple of weeks and then resolve. HSV can also complicate other skin conditions. For example, in eczema, coexisting HSV can produce a widespread herpetic infection called eczema herpeticum. It should also be remembered that HSV can sometimes cause serious infections elsewhere in the body. One example of which is HSV encephalitis, a potentially life-threatening condition requiring treatment in hospital and which, if survived, can cause long-term disability. HSV is typically treated with antiviral agents, and these can be given by a number of routes, including topically, for example in the case of cold sores. Alternatively, in some cases of HSV, we'll prescribe oral antiviral agents, or even in severe cases, intravenous agents. If people experience recurrent bouts of HSV, they may need to take prophylactic oral antivirals on a regular daily basis. Other important strategies to help prevent HSV infection include avoiding touching the lesions, and in the case of genital herpes, either abstinence from sex or the use of barrier contraception such as condoms. The next common viral skin infection we're going to look at is varicella zoster virus, or VZV, which is a member of the herpes family. In the primary care setting, we typically see two forms of VZV, the first being chickenpox and the second shingles. Chickenpox is primary varicella zoster infection. It's most commonly seen in children, although with the development of the chickenpox immunisation, this is becoming less common. Primary VZV infection is transmitted by airborne particles and also by direct contact with lesions. The incubation period is typically around 2 weeks. The infection then tends to manifest as widespread itchy vesicular lesions to most parts of the body. Lesions may start on the scalp and face and then spread to the trunk and extremities. Once formed, they eventually crust over and then fall off to leave a pink base. Typically, the patient is infectious until every last lesion has crusted over. Chickenpox in childhood is typically a self-limiting, mild to moderate infection, and most patients will make a full recovery. Chickenpox in adulthood can lead to a more severe illness and occasionally present in other ways, such as encephalitis or pneumonitis. In the majority of cases, treatment of chickenpox involves supportive measures, such as the use of antihistamines to help reduce the itch, fluids, and rest. Topical agents such as calamine lotion and oral antipyretic agents such as paracetamol may also be helpful. Occasionally, chickenpox may need to be treated with antiviral agents, especially in the setting of more severe illness such as encephalitis or pneumonitis. The other common presentation of varicella zoster virus is that of shingles or reactivated VZV. This is also referred to as herpes zoster infection. In a similar way to herpes simplex virus, once contracted, varicella zoster virus remains in the body after the acute infection has resolved, and again lives in the dorsal root ganglia of the nervous system. In some people, the virus will then reactivate, most commonly along the path of a nerve, presenting as a painful vesicular rash in a dermatomal distribution, which is usually unilateral. The symptoms of reactivation may begin as pain or tenderness along the distribution of the nerve before a rash then presents. As with chickenpox, the vesicles will eventually crust before fading. A number of complications can occur in relation to reactivated VZV. For example, if the virus involves the eye, it can sometimes lead to corneal ulceration, which, if left untreated, can result in permanent problems with vision. Other potential complications of shingles include motor nerve palsies, for example, cranial nerves, disseminated herpes zoster in the immunocompromised patient, secondary bacterial infections, and post-herpetic neuralgia. This final complication is fairly common and presents as persistent pain and on occasion sensory abnormalities in the distribution of the affected nerve long after the rash has resolved. Post-herpetic neuralgia may require treatment with atypical analgesics such as tricyclic antidepressants and anticonvulsants, medications which were initially designed for other means but found to be useful in treating neuropathic pain. The next common viral infection to consider is molluscum contagiosum. Molluscum is the result of a DNA pox virus, which typically causes a self-limiting infection in the epidermis of the skin. Lesions are typically discrete, pearly pink, and umbilicated. The term umbilicated refers to the depression in the centre of the lesions, looking a little like an umbilicus. Lesions of molluscum contagiosum are often found in groups, and the disease is typically passed on by direct contact. As such, it's most commonly seen in school-aged children, although it's important to note that it can also be passed on by sexual contact. There are a number of ways we can treat this condition, including cryotherapy, curettage, laser ablation, or topical preparations such as antiseptics and podophyllitoxin. Equally, it's quite safe to leave molluscum contagiosum, as eventually the immune system will mount a response and get rid of it, although this can take a number of months, and patients may ask for treatment due to the negative aesthetics of the disease. The next stop on our tour of common skin infections are the fungi. Broadly speaking, fungi can be divided into two main groups. The first, as shown on the left, are the dermatophytes, which are multicellular filaments or hyphae that multiply by spore formation. They're very similar in structure to the fungi that you might find growing on the surface of jam that's been left unattended for a while. The second group of fungi which commonly cause skin infections are the yeasts. These are represented in the picture on the right, and as you'll see, are composed of unicellular forms that multiply by budding. Let's look firstly at some of the common skin infections caused by dermatophytic fungi. Typically, such organisms can infect the stratum corneum of the skin, the nails, and the hair. The prefix tinea is often used to describe these common dermatophyte infections, tinea being a Latin word meaning worm. If you look at these pictures of tinea corporis, that is a dermatophytic infection affecting the skin of the body, it's easy to see from the appearance of the rash why they're referred to as being worm-like. In fact, the commonly used present-day term ringworm often causes significant anxiety in patients who think they've acquired a parasitic worm infection. Tinea corporis typically presents with well-demarcated annular lesions, which can occur on many different parts of the body. In some cases, tinea corporis can involve a significant percentage of the body surface. As you'll see from the following pictures, tinea infections can also involve other areas of the body. For example, the image on the left shows a tinea infection of the toenail, while the image on the right shows a typical fungal infection on the soles of the feet, referred to as tinea pedis. Other areas that such infections can involve include the groin, as shown in this image on the left, which is referred to as tinea cruris, or more commonly, jock itch. Also, dermatophyte infections commonly cause nappy rash, as shown here on the right. Look at the inflammatory reaction and typical satellite lesions, that is, the smaller red lesions on the periphery of the main area. There are a number of ways in which we can diagnose dermatophytic fungal skin infections. These include clinical appearance, skin scrapings which are then sent off to the lab for diagnosis, and the use of specialist light such as the Wood's ultraviolet lamp, which can cause fungal elements to fluoresce. Treatment of dermatological fungal infections involves antifungal agents, which can be given in a number of ways, including topically and systemic treatments. It's important to remember that we may need to use systemic treatments for large areas of skin infection and also for infection involving the nails, because topical antifungals are rarely effective in managing fungal nail infections, due in part to the slow growth of nails. Now that we've had a look at dermatophytic fungal infections, let's go on and consider some common yeast infections, specifically the Candida group. Candida species are commensal in the GI tract, the mouth and on the skin of most humans. However, in certain situations there can be overgrowth of Candida. For example, in moist warm skin folds, in patients who are suffering from obesity, in diabetes, in pregnancy, in situations of poor general hygiene, in humid environments, in wet work environments, after the use of some broad-spectrum antibiotics, and in those who are immunocompromised, such as people taking steroids, other immunosuppressing agents such as chemotherapy, or those with certain medical conditions such as HIV. If we look at the picture on the left, we can see a typical case of oral candidiasis in a young child. This often presents with white, plaque-like lesions on the oral mucosa and can result in discomfort in the mouth and then poor feeding. Such infection is commonly passed on from feeding surfaces such as mum's nipple or bottle teats. When treating Candida in this setting, it's therefore important to not only treat the child, but also the feeding surface concerned, either with a topical antifungal agent, as in the case of mum's nipple, or sterilisation, as in the case of rubber teats, because otherwise reinfection of the child's mouth is highly likely to occur. The middle picture shows a typical Candida infection in a skin fold. These are commonly seen in elderly patients and can be managed by addressing any potentially reversible factors mentioned previously, in addition to use of a topical antifungal agent. Other common places to find fungal yeast infections include interdigital spaces, as shown here in the image on the right. Again, treatment is focused on correcting any potentially reversible causes and the use of a topical antifungal agent. Yeast infection in the interdigital spaces between the toes is particularly common and known as athlete's foot. The final common yeast infection to consider today is that of pityriasis versicolor, which is also known as tinea versicolor. It's important to note, however, that despite being referred to as tinea, this is not a dermatophyte infection, but is, as previously stated, a yeast. Typically, pityriasis versicolor affects the trunk, neck and upper limbs, and it's uncommon to find it in other parts of the body. Patches of the disease may be a multitude of colours, including pink, coppery brown, or pale when compared to surrounding skin. Sometimes they'll be mildly itchy. When the condition affects dark-coloured skin, it will typically leave pale patches, a condition known as pityriasis versicolor alba. This is less likely to be itchy. When we use the Wood's ultraviolet light, patches of pityriasis versicolor may fluoresce, a characteristic which can aid in diagnosis. Skin scrapings can also be helpful for analysis in the lab. This condition is more common in hot and humid climates or in those who sweat heavily. Treatment commonly involves either topical or oral antifungal agents. Finally, we now move on to other common skin infections not otherwise covered in the above topics. The images here relate to a skin infestation caused by the mite Sarcoptes scabiei, which leads to the infection commonly known as scabies. The scabies mite is typically passed on by direct contact with infected individuals or with items such as clothes or bedding that the scabies mite inhabits. Hence, it's not infrequently seen in situations such as overcrowded living conditions. Scabies present with an extremely itchy rash, the typical lesions of which are tracking burrow marks, as shown in the middle picture here. When the scabies mite lives under the skin, it drops feces within the burrows, and this leads to an intense allergic reaction to the feces and subsequent itching. Scabies infection can occur anywhere on the body. Common sites include the interdigital spaces, limbs, buttocks, and trunk. Scabies can also be found around the genitalia and in some cases is sexually acquired. The image on the right shows something called crusted scabies, which was previously known as Norwegian scabies. This is a particularly contagious form of scabies in which the individual may be infested with millions of scabies mites. In crusted scabies, the patient will present with a generalized scaly rash, often again prominent in the interdigital spaces, wrists, elbows, breasts and scrotum. It's important to note that there may be minimal itching in crusted scabies. There are a number of potential risk factors for crusted scabies, including elderly age, suffering from malnutrition, having an immune deficiency, having an intellectual deficit, and neurological disease. The treatment of scabies involves a number of measures, including topical insecticides such as permethrin and oral agents such as ivermectin. It's also important to look for and treat any secondary bacterial infections which may complicate scabies. This is managed with appropriate antibiotics as described above. It's also important to treat household contacts and to clean any fomites such as clothing, sheets and bedding. The latter process needs to be done in very hot water before hanging fomites out to dry in the sun, as the scabies mite is killed by ultraviolet radiation. We'd usually recommend repeating insecticide treatment a week or so after the initial course. Don't forget that the itch associated with scabies infection can occur for some weeks after the mites have been destroyed due to an ongoing immune sensitivity to the feces, and it's vital to let patients know to expect this, or else they may think the insecticide treatment has failed. Antihistamines may help to reduce the itch. This brings to an end today's presentation about common skin infections. I do hope it's been helpful. Please find a list of references enclosed. Thank you.